Hi guys, today we're going to talk about diabetes, both type 1 and type 2, and then also some pregnancy-specific implications. So diabetes is all about how the body metabolizes one of its primary energy sources, being glucose, and the balance between storage, intake, and distribution and utilization. As you guys probably are well aware, muscles, brain tissue heavily rely on glucose as an energy source. It's very important. However, in type 1 diabetes, there is a lack of insulin production due to the pancreas basically attacking itself. Sorry, there's an alert on my computer there. And then in type 2 diabetes, you just have usually what happens to be an increased amount of glucose circulating in the body, either from poor diet. Sometimes there's some genetic factors involved as well. But over time, that can lead to insulin resistance. This is just a brief diagram kind of showing the conversion. I'm not going to spend much time on it. Complications involving diabetes. I think of diabetes having very similar complications as uncontrolled hypertension, and really the two often go hand in hand. The way you can think about glucose molecules is, I think of kind of like small shards of glass, bits of grains of sand, or however one you picture it. A small amount in the bloodstream is fine and normal. If you have too much, over time that can wear down vasculature, and specifically the microvasculature. And if you combine that with high blood pressure, it can put more pressure on those end organ areas. So heart, brain, eyes, kidneys, and peripheral neuropathies are also seen for diabetic patients. I'm going to spend a few minutes talking about type 1 diabetes. Type 1 is pretty straightforward. Really, it's a chronic disease. It's an autoimmune disease. And it's very commonly affecting children. So younger patients will have this. If they have it, they usually develop it at the latest by their teenage years. Basically what happens is your pancreas, you're born with a functioning pancreas that has a large amount of beta cells. And over time, as your body reacts to those beta cells and destroys the pancreas, you lose your endogenous capability to produce insulin. This is just an interesting rate comparison if you're curious, looking at prevalence of type 1 diabetes in children's age 0 to 14. And you can see that places that tend to have European heritage, or Europe specifically, especially Northern Europe, seem to have a higher incidence. So why that is, we don't really know, but you can definitely see like Scandinavia, United Kingdom, and then also places like Australia, and Canada, also being British colonies, which would make sense why there's high relationships there. So it's just kind of an interesting thing to think about, but nothing more than a correlation. I'm going to skip through this. Basically, the moral of the story is here. There's a lot more documentation of the disease now than there was, and a lot better diagnosis, I guess, early diagnosis. So incidence is rising, but it could just be due to the fact that we're catching it earlier and that we're seeing more of, we're catching it in more appropriate patient populations that maybe previously didn't have better access to healthcare, or weren't being identified as diabetic patients. Sorry. Okay. I'm going to skip this. This is just something in case you're curious. I put this on here. So symptom onset, usually you're looking at polyuria, polydipsia, and weight loss. With your populations, you're probably not going to have anyone with symptom onset, I would imagine. However, you could have parents of young children, potentially, who are seeing you for primary care. They may talk to you about this, so it's probably worth knowing a little bit about it. But symptom onset for either type 1 or type 2 diabetes is really the same. You're going to end up with increased urine production, body's way of getting rid of excessive glucose. Polydipsia, excessive thirst, again, the body wanting to dilute out the serum glucose concentration and also help flush the kidneys so that they can continue to remove glucose. And weight loss. Usually there's some nausea and anorexia associated with severe cases, but you also get impaired glucose utilization, so fat and muscle cells may start breaking down. Any patient with type 1 diabetic, or any type 1 diabetic patient, is going to be insulin dependent, and so that's where you hear the term insulin dependent diabetes. It's the same thing as type 1 diabetes. You can use insulin in type 2, which we're going to discuss a little bit later. Therapy starts with diagnosis of the disease. As soon as you know somebody has type 1, you start them immediately on insulin therapy. That's the only thing that's going to help. So we want to prevent any long-term complications. And ultimately, if you supplement the insulin correctly, people can live a relatively normal life. There shouldn't be any real complications to it. The risk being maybe overdoing the insulin and having a hypoglycemic episode. But of course, that's something we can monitor for as well. And then there's lots of products available and insulin pumps that people use. Pretreatment options. We'll talk about two major aspects of treatment. There's a conventional treatment, which is historically was single or twice daily injections. Not really effective anymore, and it's fallen out of favor completely. The only time you ever see people on a more conventional regimen, and I've never seen a type 1 diabetic patient using single once daily injections, but sometimes you will see twice daily, and this just comes from usually either very poor adherence, and really the most they can do is twice daily, so it's better than nothing. And also you'll see patients who have cost issues too and can't afford maybe some of the products associated with the more intensive regimens. Intensive regimen is designed to mimic physiologic insulin. So what you're usually doing with intensive is you're giving some sort of basal insulin. So it's a long-acting insulin that's going to be in your body at all times, and so it's your body's ability to use that at its discretion. Apparently my computer needs lots of updates today. Anyway, sorry. And then the other component of intensive is mealtime insulin. So every time you eat and your blood sugar rises, your body will automatically release insulin. It's going to do the same thing in this treatment strategy where we're going to be giving rapid-acting insulin with each meal. Insulin comes in a number of forms. I say this the old way and the new way. The old way, people used to pull out of vials and do injections using small needles like this. Now the more common way is with these pens. The pens, you can see on this Levemir product here, you can actually dial these back to the number of units you want to inject at a time. And then you screw on what's called a pen needle, which is this little capped portion here. So these are single use. You can see the small needle here. Then you inject subcutaneously just like you would with a syringe. The thing to remember about pens is they're a little bit more expensive. So sometimes you will have patients who do the vials because you can generally get a little bit better bang for your buck if you're purchasing the vials. So cost is a big deal to people. They might go with the vials, but the pens are definitely more convenient. Okay, so a couple options for insulin. Talk about basal insulin. This is your long-acting. Insulin glargine is Lantus, and insulin detamir is Levemir. These are your two really only basal insulins on the market, and any intensive regimen will be compromised of one of those. The only exception, so basically you're going to see all diabetic patients on these. The only exception you'd have is people who use pumps. Usually the pump is running a continuous infusion of some kind of a rapid insulin, so they might not be using any basal that way, but that would be a pump-specific patient. There's some intermediate acting products, so NPH, which stands for neutral protamine hagedorn, which isn't important to remember other than knowing that it's NPH. And then there's regular insulin. Regular insulin is bioidentical to endogenous insulin, and it's got a slightly faster onset, but it's still considered immediate acting. Regular insulin is good to remember because it's the only product that's IV that we can give IV. So in situations where you have a person in diabetic ketoacidosis or with extreme hyperglycemia, they're going to be using regular insulin IV for that. Or if you put somebody on an insulin drip while they're in the hospital, that's going to be regular insulin. But it's kind of a hybrid between rapid and intermediate. It's got a fairly fast onset, but it also sticks around for a while. And then there's rapid-acting insulin. These are the mealtime insulins. Excuse me. These mealtime insulins, there's three major products, Novolog, Humalog, and Apidra, and they're all essentially interchangeable. Novolog and Humalog are by far more common than Apidra. And there's some combination ones that have a combination of NPH or regular. They might have rapid acting and regular, or rapid acting and a modified, like the Novolog 7030 has this modified aspart and then regular aspart too. So it's just different combinations. It gets kind of complicated. Combination products I don't think are all that successful. You'll see them occasionally used, but again, what's more common is going to be your basal insulin plus some sort of rapid acting with meals. This just compares the kinetics of the different agents and knowing how they work. So we have our endogenous one, which is kind of this brown tan line here that gets released within the body and works very quickly. The body can get away with using very small amounts of insulin and being very effective because it's getting right to the source very fast. And then you have different types here. So you have the rapid acting mealtime insulin, which is the black one here. Remember, there's a bit of a delayed onset here because you're injecting them subcutaneously. It does take a little bit of time for that to absorb systemically. So you're seeing like, it's saying the Tmax is at what, like 1.5 hours here. So it probably works a little bit faster than that, but that's about what you'd expect. But you're going to get some decent effects even very early as this peak increases. So with meals, or usually people are doing it slightly before meals, checking their blood sugar maybe 30 minutes before their meal. If it's normal, they're looking at how many carbohydrates they're ingesting, and they're calculating a dose based off that. And we'll talk about that in a second. This is just a reference for you guys to compare. It talks about all the onsets, talks about the costs associated with them. Choosing products, and there's essentially, a lot of these are essentially interchangeable. Lantus, which is actually, sorry, I should say, the insulin is actually Glargine, and the brand names are Lantus or Toujeo. Toujeo is a new Glargine product that is more concentrated. So for most standard insulin products, the concentration is, and I'll write it on the slide so you guys can visualize it, it's 100 units per ml. Now, some people who require more, and this mostly happens in resistant type 2 diabetic patients. So in type 1 diabetic patient, probably not going to get to this point, but you could potentially. And they might just be injecting so much. So if you're injecting, like I've seen people inject like 80 units of Lantus twice daily, that's quite a bit. And a pen itself has 300 units total insulin in it. So you could imagine how many pens you're going through. This Toujeo product is a pen that's 300 units per mil. So it's triple the concentration. And it will come with in the same type of pen. Now, the only really important thing to do is make sure the patient understands how to dose it, because if they make an error, that could be catastrophic potentially. They could be injecting themselves with way more insulin than they need, and that could be deadly. So it's very important to make sure the patients understand the concentration differences, but these products can be convenient for patients. Lantus is listed on here as my primary basal one. Detamir or Levemir, the brand name. Remember, say Levemir. It's insulin Detamir. That's an equally effective option. The problem with Levemir is it's just not quite. It doesn't have quite the smooth peak, lack of peak, I should say, of insulin Glargine. So if we go back to our other slide here, you can see our long-acting Glargine. They combine here Glargine and Detamir. In actuality, Detamir is going to have more of a bell curve shape, a very flat bell curve, but still going to have a bell curve. Glargine is going to rise up slowly. It's really going to be quite stable throughout its process. It's going to last about 24 hours. It's not going to dip much. And assuming you're redosing it, it should stay very steady within the body. That's the design for it. Detamir tends to have bit more of a peak and an onset offset than Glargine. So Glargine is almost always used, but you do see Detamir occasionally. Just get rid of this here. Novolog, Humalog, Aspart, and Lispro. And I didn't include Epidra here because I don't think it's used very often, but essentially interchangeable. Insurance may cover one or other. They may cover both. Our hospital has Novolog on formulary, but Humalog is equally, they're essentially exactly the same. They work the same. Other regimens, there's twice daily NPH could be one that is done. I've seen regular insulin. Regular insulin is probably the cheapest of all the products. So if you buy a vial of regular and you're doing a 3 to 4 times daily regimen, again, not as ideal as the intensive style with the basal plus mealtime, but it still might be effective. And then Levemir plus Novolog, again, you could do that in place of the Glargine, and combination of anything really. So you could get really kind of wild with your regimens and do the combination products in addition to long acting. But really, I think to keep it simple is best, but sometimes you might have to get creative with patients. If you're ever in a situation where you feel overwhelmed with insulin, I'd recommend referring somebody to a diabetic specialist or endocrinologist. I put the U500, U300, U200, and this is just the nomenclature we use to discuss what. So U500 is 500 units per mil. And you can see that with the different concentrations, it's really important. So like, where would you need a 500 unit per milliliter concentration? Well, there is a regular insulin product that's super concentrated, 5 times concentrated. It is called U500. It's been associated with a lot of errors in the hospital setting, so it's important to be really careful with it. If you ever hear a patient, they tell you they're taking U500 insulin, you need to be really careful with their dose and make sure that they understand what they're doing and that you understand what their dose is, because errors can be made easily with that. And again, giving somebody too much insulin can have really bad consequences. All right, so an initial regimen for a patient, just to give you guys an idea. Remember, this would be usually for a child or a teenage patient. Weight-based dosing and adjusting from there and making sure that blood glucose is staying within normal limits. That's really all we need to do with these patients. It's an easy thing in theory, but it can be obviously challenging for people. But once you get your weight, usually splitting it and giving basal as half and your meal times as half. The mealtime insulin is going to be a couple different ways we can try this. The common way you're going to see is a sliding scale plus some sort of either fixed dose or carb counting with meals. So what I was alluding to earlier is that if a patient maybe, before they're going to eat or 30 minutes before they're going to eat or something, they'll test their blood sugar and then they might follow a sliding scale. So if their blood sugar is 200, let's say it's 205 just for sake of our scale here. So if it's 205, they're going to be giving themselves 2 units of insulin. So let's just do a little example here. So our blood glucose is 205. We're going to be giving 2 unit sliding scale. But let's say they're also carb counting and they're doing 3 units per carb choice, as you can see here. And maybe they're taking let's say 3 units of carbohydrates. So they're going to add 9 units there equals 11 units. Oops, if I can spell here. So you can see how people might make these regimens work by doing a sliding scale plus. And the sliding scale is designed to balance out any excess glucose. So if somebody's not controlled with their normal, so if somebody's riding a little bit higher throughout the day, they can add a little bit there with a sliding scale. And also use the carb counting strategy to cover their mealtime insulin. You may have patients just on a fixed dose, so they may just I've had patients who are like, yep, I do 10 units every meal. Doesn't matter what the meal is, doesn't matter what I eat, I always do 10 units. Okay, that's probably not the most ideal way to do it, but some patients, the carb counting plus sliding scale is kind of an advanced strategy, and there may be patients who don't adhere to that specific of a regimen, so you could see a lot of different strategies there done, but ideally, I think carb counting plus sliding scale is probably the best option for most patients. Monitoring, there's a lot of glucometers out there, a lot of different companies that make them. It's essential for any diabetic patient, type 1 or type 2, to do regular monitoring. They come in a lot of different styles, but basically they're all the same. You put a test strip in, you prick your finger, you put the strip attached to the meter up to your finger, get the blood onto the strip, it'll read it and give you a nice big clear window saying what your blood sugar is. Most test strips have a memory system, so like if you have your patient come in, you can, or most glucometers I should say, you can check their glucometer and see what their data is. I think some communicate with smartphones now and have apps so that they can store things like that. So we're going to see more technology coming out for that, I'm sure, as things improve. And ultimately, at some point, people might be using their smartphones to check their blood sugar if they aren't already. Testing usually 4 to 7 times daily. People usually think of with every meal and at bedtime at the minimum. And then if patients are exercising or doing something else, maybe they eat a lot of snacks or, who knows, you could use your imagination to figure out a lot of scenarios. Exercise is probably particularly important for type 1 diabetics to make sure they aren't on the hypoglycemic side before they go into an exercise regimen or they go running or something. A single blood glucose is really only a snapshot, and it's important to look at your trends. So knowing how to access the data on the glucometer, or if your patient keeps a diary of their blood glucose. And so the trend is really what's big. If you have one, glucose of 300 and everything else looks in range, well, you can probably take that as a fluke and not really give too much, not really get too concerned about that. Hemoglobin A1C is a measurement of blood glucose over about the past 2 to 3 months. So it's about how hemoglobin binds glucose. And it's a more predictive measure of how in range you are. And hemoglobin A1C isn't something we really care about with type 1 diabetics patients. It's much more for type 2 monitoring. We'll talk about that in a few slides here. Talked about pumps. Pumps are essentially a continuous infusion of a rapid-acting insulin, so it replaces the basal insulin that way. And then pumps can be programmed to give bolus doses, or you can manually bolus yourself off the pump. So if you if you can maybe program it with a mealtime dose and do something that's going to give you a bolus during your meal. You can program how many units you want to give it for a meal. Some glucometers are advanced enough, like this system here, which I don't think a lot of people use. It's probably not very convenient, but you have the pump hooked subcutaneously up here, and then you have another sensor that's measuring blood sugar here. So this is constantly measuring blood sugar, communicating with the pump, telling the pump what to do. And that's, I think, where we're going when we talk about like an artificial pancreas. Essentially, this is an external artificial pancreas and really doing the same thing. The other nice thing about pumps is that you end up using less overall insulin with a pump because it's just more efficient. It does require you to be a very adherent patient too. If you mess up your pump or your pump malfunctions, you need to know how to react to that. You need to be able to monitor your blood sugar and make sure you're not getting hypoglycemic too. So most people probably find the pump to be a lot more convenient than the regular injections though. Hypoglycemia, if blood sugar is lower than 70, you can end up with some severe issues. So these are kind of the basic symptoms you would have. We talked about beta blockers last module with the hypertension stuff, and really tachycardia is one of the signs of low blood sugar. So if you're on a beta blocker, that could block that symptom. So that's one of the reasons why diabetics are counseled when they take a beta blocker, to make sure that they know that they aren't going to get tachycardic. These are some of the standard symptoms. Ultimately, people can get altered mental status, seizures, and you can ultimately die from being hypoglycemic. So it is important. Fortunately, it's relatively easy to correct. You can give some sugar, and that should recorrect that fairly quickly. Even just some simple glucose. There's a lot of products out there that are tablets that are glucose tablets or glucose gels that you can take that absorb very quickly through the GI tract and also through the oral mucosa, and get into the bloodstream fairly fast. Glucagon is something that's sort of an emergency kit people carry with them. In the hospital setting, it's pretty easy to treat hypoglycemia because we can give IV dextrose. Dextrose, the problem with it, it's a fairly large syringe. It's like 50 mils. If you're a nurse and you've worked in any type of moderate acuity area, you've probably seen them, but they're fairly large syringes. So most people aren't going to carry around with them a big dextrose syringe and start an IV if they're hypoglycemic. So glucagon is a rescue kit that can be used in the field fairly easily. It's very small. It's a small amount, and you can inject it IM or sub-Q. Basically, it's a synthetic version of an endogenous peptide hormone that is also released by the pancreas. And so if blood sugar gets really low, your body will release this as a reaction. But in people who have type 1 diabetes, whose pancreas is severely damaged, probably not going to react as well. So we can give this as an alternative to the endogenous hormone. And it works the same way. It's very fast, but it's not quite as good as giving somebody just pure sugar IV. But again, we can't always do that very easily. Ketoacidosis, basically you're looking at fluid replacement, IV insulin, high doses. One thing I'll just point out about this is when you give somebody IV insulin, you're giving somebody high doses, it drives potassium into the cells. So it's really important that we monitor potassium. Obviously, you're going to be monitoring your blood sugar, but sometimes you'll have to replace the potassium aggressively to make sure they aren't getting hypokalemic. Hyperosmolar hyperglycemic state, excuse me, very similar to DKA, but no keto acid accumulation. DKA is more associated with hyperglycemia for type 1 diabetic patients, and HHS is more associated with hyperglycemia in type 2 diabetic patients, but very similar treatment you're giving insulin to get the blood sugar down. All right, type 2 diabetes. This is my joke for the day. Think of the standard type 1 diabetic patient is kind of being lean. Michael Phelps, I highly doubt, I'm pretty sure doesn't have type 1 diabetes, but I think of like somebody who's lean, and generally type 1 diabetic patients are kind of going to run on the leaner side of things. Type 2 diabetic patients usually got that way because of diet and lifestyle choices for the most part. There is some genetic component there, so I don't want to put it all on that, but I think of them being a little bit more on the obese side. You can see there's a lot of things that contribute to type 2 diabetes, and ultimately you end up with too much blood sugar, and your muscles just can't use them. Insulin gets resistant, and it causes a cascade of problems. It's sort of a slow thing. It doesn't happen quick. The damage won't happen quickly, and it takes a long time of increased blood sugar to really cause severe effects with that. This I'm not going to go through. It just talks about sugar. Sugar is sugar. No matter how you consume it, you could be at risk. So even if you're drinking a lot of juice instead of pop, that's still sugar. I think probably everybody knows that. Increasing body weight increases the risk of diabetes. Here's just some charts that show some of the stats on that. I'm not going to spend much time on that. You can check it out if you want to. Type 2 diabetes is a very common chronic disease. About 8% of the U.S. population has it. It's thought that out of all the people in the U.S. that have it, 25 to 40% are undiagnosed. Out of all the diabetic patients, 90% are type 2. So when we're talking about type 1, it's a very small subset of diabetes, relatively speaking. So type 2 is really the more common one. However, it's much more common in older people too. It's something that usually catches up with you as you age and have been maybe neglecting your diet for several years. It can happen in kids, it can happen in young adults too. It's definitely possible, but we usually associate it more of a chronic disease that catches up with you from a complication standpoint later in life. So people may not report symptoms like visual changes until they've been diabetic for several years, and now it's finally catching up with them. Normal labs, fasting blood glucose should be less than 100, and A1C should be less than 6.5. And these are really the measures we're looking at. A1C is very important for any type of type 2 diabetic measure. And again, it's that picture of 3 months worth of data in one lab value, as opposed to checking blood sugar here and there. You have to rely on your patient's adherence. You have to rely on their documentation in some situations, but the A1C is just a nice snapshot. So if somebody's A1C is over 6.5, if they have a fasting blood glucose over 126, you can retest them and do a 2-hour blood glucose after they've had oral glucose. So they consume oral glucose and then they get their blood sugar checked. If you've done any glucose tolerance tests for pregnancy or worked with patients who have done that, it's a very similar process. We're going to talk about that in a few slides. But hemoglobin A1C, glucose molecules bind to hemoglobin, and that's how this is checked. So depending on how heavily bound the glucose is to hemoglobin, you're going to get an increase in A1C, and over time, that's how we can tell how things are reacting to medications or dietary and lifestyle modifications. Nonpharmacologic options are very important to go over with patients and something we should always start with. So diet, exercise definitely have been shown to be effective. However, the problem is that people usually just aren't compliant with exercise programs. Diets don't stick. So unless you have a really motivated patient, it can be difficult to go about non-pharmacologic options. Not to say you shouldn't try, but just to be realistic with your expectations. Very small amount of percentage of patients clinically have been shown to be able to control type 2 diabetes. There was a study in the UK, a pretty big study, that looked at achieving fasting blood glucose goals with a lower calorie, low fat, focus on high complex carbohydrates versus simple sugar diet. And only 3% of the patients actually achieved the fasting blood glucose goals. Now, you could argue whether that's an ideal diet for this or not, but the point is that they tried to cut calories, tried to cut down on non-complex carbohydrates, and they still weren't able to really do it. They also had an exercise component with it too, and found that the compliance was very poor with that. So again, clinically, there's not a lot of great evidence for that, but it's not to say you can't do it. It's just you need a motivated patient who's willing to put in the work. And also, if your patient's A1C is extremely high to begin with, probably going to want to start them on medication. Even if you think that they're going to benefit from exercise or they're going to stick to it, it wouldn't hurt maybe to start medication and lifestyle at the same time. And if their A1C dramatically improves, you can always say, let's try it without the medication and see how you do with just lifestyle. That's definitely fine. But for early onset, if the A1C is quite high, I would definitely recommend going straight to some sort of medication to help manage that in the immediate phase and then work on the lifestyle at the same time. So metformin's our major drug here. It's by far the most effective clinically. Any type 2 diabetic patient is likely to be on metformin. It's really a medication that has been the cornerstone of diabetes therapy for a very long time. It does have a few contraindications, but I'll talk about its mechanism quick. So it's got a threefold mechanism. You're decreasing hepatic glucose production, decreasing intestinal absorption of glucose, and increasing peripheral glucose uptake and utilization. What I'll note about the mechanism of metformin is that there's no effect directly on insulin. The reason that's important is because it's very rare, if not impossible, to get hypoglycemic from metformin. Another great reason why the drug's so successful. There's virtually no risk of hypoglycemia. Now, there are some other side effects. There is a kidney function contraindication. So if you have a borderline increased serum creatinine and the cutoffs you can see here, it is contraindicated. Also, if you're getting iodinated contrast media or some sort of surgical procedure, they usually hold metformin. Again, it's because of this problem with kidney clearance and metformin. It's thought that if you can't clear metformin correctly, it's associated with causing lactic acidosis. Now, this is a really loose association that hasn't been vetted very well clinically, and a lot of studies have actually come out to say that metformin doesn't really have much of a risk with this, but it's still something that's reported occasionally, and it hasn't really gone away. So we do take it seriously. We do pull it during if people are having acute kidney injury or kidney issues. The more common side effect is GI related: diarrhea, nausea, vomiting, flatulence, up to 50% depending on the side effect. There is an extended release formulation of metformin that usually has better tolerability. So that's something you could switch to if the patient's not tolerating the regular product. Sulfonylureas are sort of the second line. They've been around for a while. They have pretty good A1C reduction, one of the more effective oral medications. The problem is that they stimulate insulin release from the beta cells, and they're fairly good at doing this, meaning that they have a pretty high risk of hypoglycemia. So the problem with them is really that they're going to be aggressively working with insulin, and that's good and bad because you're going to be at risk for hypoglycemia. If people take them and aren't eating very well, or if they, some of them are renally eliminated, and that can be a problem too. These are the three major drugs in the class: glipizide, glyburide, and glimepiride. The nice thing about glipizide is there's no renal adjustment needed. So if you have a patient who can't take metformin because they have kidney problems, they could go to glipizide. Now, just know that glimepiride or Amaryl is renally adjusted. So not all sulfonylureas qualify, but glipizide's a good alternative to kind of keep in the back of your mind. It is, in its regular form, it's fairly short acting. However, there's an extended release formulation available that keeps it nice and steady, also decreasing the risk of hypoglycemia. Especially for patients who are exercising or tend to miss meals occasionally, that can be the biggest problem for sulfonylurea hypoglycemia. So the next category of classes I'm going to go through all have roles in various patient populations. Now, who depending on who you talk to, they may have different opinions on which one is first line or not. I think what I just talked about, metformin and sulfonylureas, represent the lion's share of what's used as far as oral hypoglycemic agents. The rest of these agents are all used sporadically. Some people like others more than certain ones. I'm going to go through them very quickly. They're here more for a reference. Not to say that you shouldn't know them, but if you work with patients that have diabetes, probably important to at least be exposed to them. But I'm not going to go through the mechanisms of all these. You can go through that through the slides if you're curious. But we've got Meglitinides, Prandin, and Starlix here. I believe Prandin is now, I say they're brand only expensive, but I think Prandin's still brand only, sorry. So the other thing about these next group of drugs that we're going to talk about, they're almost always expensive in brand. So the sulfonylureas and metformin have been around for a while. They're relatively inexpensive. These drugs are not cheap. We've got a couple different ones here. Prandin is nice because it doesn't have any renal adjustment needed, so there's that going for it. They're similar, slightly less effective than sulfonylureas. They have kind of a similar mechanism, so glucose-dependent insulin release, but they have a lower hypoglycemia risk, so that could be an advantage of them over the sulfonylureas. The Thiazolidinediones were one of the very commonly used classes of drugs for a while, but they've kind of fallen out of favor. There's two sort of on the market. Pioglitazone is the more common one. Put a little side note down at the bottom there. It says France and Germany removed them from the market because of potential bladder cancer risk. Basically, they reviewed the product and said, well, there's so many other oral hypoglycemic agents that we don't need to keep this one on the market. The other product, rosiglitazone or Avandia, was removed from the market in Europe and heavily restricted in the U.S. due to some perceived increased risk of myocardial infarction. However, the FDA reversed this decision in 2013. I don't think it's really helped the cause of this drug. I think it's still very rarely, if ever, used. So it really damaged that drug's brand, even though the restriction ended up being kind of bogus based on clinical evidence. So unfortunate for that company. DPP-4 inhibitors are a commonly used class of drugs. So these are going to work with incretin hormones. They're also going to increase insulin secretion. So the A1C lowering is a bit all over the place with these. It's modest, I would say, compared to metformin or sulfonylureas. They're expensive, although I actually think Januvia, I'm pretty sure, has gone generic. So this is one of the only drugs of these newer classes we're talking about that is generic. So I say they're expensive, but I think sitagliptin is relatively affordable at this point. SGLT2 transporter inhibitors are two of the new products. You might see these on TV advertised now because they're, especially Farxiga is getting a lot of airtime, it seems like. What these do is they're a new mechanism that reduces resorption of filtered glucose. Two major problems with these. One is that they're renally adjusted. So if you have patients with any type of even moderate renal dysfunction, they're not recommended. So GFR less than 60, well, that's any patient who has pretty much moderate renal dysfunction. So that's going to rule out a lot of your diabetic patients. However, theoretically, if you have somebody in early disease, these drugs might be a good option for maybe a metformin intolerant patient. Maybe somebody has really strong GI side effects to metformin, but their kidneys are still good. They're early in the disease, younger patient could consider using these medications. The other big problem, especially with female patients, are these UTIs, fungal vaginosis. The reason being, if you think about the way these medications work, what you're doing is you're urinating out more blood glucose. So the urine is itself providing an energy source for flora in the urinary tract and also in the vagina. And if there's enough of that process going on, you can end up with an overgrowth of certain species, and that can cause infections. So that's one reason why it's probably not the best option as well. Also, the clinical trials that got this approved showed pretty minimal A1C lowering effects. However, I just read a recent study that compared them head-to-head against the DPP-4 sitagliptin and showed that they were more impactful with A1C lowering than that. So I think ultimately they are decent at lowering A1C, but the question is their place in therapy. Again, they have some interesting side effects. I'm not sure if there's something that we should be really jumping on board with right away, but it'll be interesting to see where they get used. Also, very new drugs, brand name, expensive. GLP-1 agonists are pretty decent drugs. They are quite expensive. They're kind of like dosed the same as insulin. So you see this Byetta here. That's how the product looks. It's a pen, so it's very similar to insulin as far as how the delivery mechanism is. It's not insulin though. It is works by increasing glucose-dependent insulin secretion, and then working with some glucagon too, and helping with gastric emptying. So it's got a couple different mechanisms there. It's not ever used as monotherapy, but this is a good adjunct agent for patients. Now, with type 2 diabetic patients, you always run into the issue of injecting stuff versus taking oral medications, because you can get pretty decent A1C lowering with just oral medications and lifestyle modifications. So the question is, when do you go to an agent like this? Well, if your patient's really opposed to injecting something, you might want to try some orals first. But if they aren't, and their insurance covers it, this is a good second-line option to add on, to metformin or to a sulfonylurea. And you can see the products. There's a couple different products on the market. There's some differences with immediate release versus ER. For example, the ER product of exenatide lowers the A1C very substantially compared to the regular ones. So there's actually some pretty good data to support that extended release. But these products are definitely not cheap, and a lot of insurances may or may not pay for them. I'm going to skip these. They're really just work in the GI tract to prevent absorption of glucose. They have modest A1C lowering benefits. They're hard on the GI tract with flatulence and diarrhea, and most people don't take them. Insulin wasn't used a lot historically for type 2 diabetes. In fact, it was reserved for people really who have failed oral hypoglycemic agents. And most current data has actually gone against those historical thought processes, and we now use it a lot earlier and more aggressively. So the treatment is very similar to type 1. However, in type 2, we're usually just starting with basal insulin. So there's some evidence actually to say that if somebody comes in and they have a really high A1C, skipping metformin and everything altogether and just going straight to basal insulin. A lot of times people will use combination, though. They'll use metformin plus glargine. And that's a really good strategy. Again, you might run into the issue of whether or not somebody is comfortable injecting themselves, but this is going to be a more effective strategy than virtually anything else we've talked about. So it is something that is being used more and more frequently. You can also do intensive insulin dosing. You can do mealtime insulin. That'd be later. You'd always start with basal, and usually start with basal plus some sort of oral medication on top of it, and then maybe go to a mealtime strategy if that wasn't working. All right, so here's just some stuff to think about. Again, you can go a lot of different directions with diabetes type 2. I think your first line is really diet, exercise, and metformin, and maybe thinking about the Lantus or glargine if the A1C is quite high, so over 10. If you have some sort of metformin contraindication with a kidney injury, or whether you have a problem with the GI component of side effects with metformin, consider sulfonylurea, repaglinide, or doing glargine at this point. And then you can really go on. You can do, I didn't put the GLP-1s, but they would be fine here too. There's a lot of things we could add. So you could put like a, I don't know, you could put a GLP-1 in here. Let's see if I can do this. GLP-1. You could even maybe make an argument for the new drugs, which I can't remember their acronym, but the ones that decrease glucose filtration. So the or improved glucose filtration, I guess I should say. But they're like Farxiga, something like that would be fine. Okay, this up-to-date diagram I think makes everything very clear. You can go and look at the diabetes guidelines, and I didn't put anything from them specifically because I think they're kind of confusing. They go in a lot of different ways, and they basically say you can really do whatever you want. There's a lot of evidence supporting all of these medications. But I like this because it's very clean. So really what you're looking at is lifestyle changes in metformin in all cases. And then if that doesn't work, you go to basal insulin or you go to a sulfonylurea. If that doesn't work, I would maybe do a combination of these. So you could go with this and you could do metformin plus basal insulin. Maybe that doesn't get you where you want to go. Well, you could add the sulfonylurea in if you want. Or you can go straight to intensive insulin. Maybe you keep, but in everything here, you're keeping the metformin in play. And you can see metformin plus a GLP-1, metformin plus pioglitazone, triple therapy here with orals. Multiple ways you can do this. So there's no real right answer to this, and it depends on how your patient's going to respond. It depends on if your patient has kidney issues. It depends on a lot of different variables, patient insurance, depending on what they can afford. So you can go a lot of different directions. But again, I like this chart because it's pretty simple and it streamlined things. I think, again, the data is showing that if you can get to insulin earlier, it's likely to have better outcomes. So I always think about basal insulin. All right, so more important maybe for your guys' practice, gestational diabetes. So nutrition and exercise and frequent monitoring are all things that are part of treatment of gestational diabetes. Testing for this, all pregnant women will do the glucose tolerance test. So take 50 grams of glucose, check the blood sugar 1 hour. If it's less than 130, that's a pass. If they fail it, they drink 100 grams of glucose and take blood sugar 3 hours later. And it's the same rate, the 130. If they fail that, then they're technically diagnosed with gestational diabetes at this point. Important to note that while people who have diabetes are maybe at more risk for gestational diabetes or will carry in their diabetes to pregnancy, people who have no history or people who can be very in shape can definitely have gestational diabetes. In fact, it's much more common too with people who are pregnant with multiple births. I believe twins and up have much higher risk of gestational diabetes than single births. So what medications are okay in pregnancy? We talked about a whole bunch. The old standards are usually the best. So insulin has some data, some different insulins. Both Lispro and Aspart, so our mealtime insulins, have been studied in pregnancy. They've been shown to be pretty effective. As far as long-acting, the problem with long-acting is we haven't really had good data to support using glargine. There's some data that probably shows it's okay, but we don't know that for sure. So usually NPH, as far as a long-acting agent, has the best data. So if you had somebody with type 1 diabetes come in and they're on an intensive regimen with glargine and Lispro, you could maybe switch them to an NPH Lispro regimen. So you're switching to the NPH maybe twice daily to give them that long acting, and then adjusting their mealtime insulin appropriately and just making sure they're monitoring regularly. Oral agents would be things like glyburide, which hasn't been shown clinically to be as effective as insulin, but is okay in pregnancy. Metformin is also okay. Specifically in the second and third, there's some issues maybe within the first trimester. But if you're diagnosing with gestational, usually probably looking at second and third trimester anyway. I would say that if you have a patient coming in to pregnancy, they're on metformin for diabetes, it is something worth looking at. There is some risk potentially within the first trimester, but it would be something to go over the benefits and the risk of the patient. You might want to switch them to either insulin or maybe switch them to glyburide. I talked about glargine and detamir not being significantly studied already. The thing about glargine too is that it's such a very constant basal rate that if you have a pregnant patient can have various dynamics in their needs for insulin, and having that constant basal could put them at risk for hypoglycemic. Also, if you need to make an acute change in the patient, the onset is much too slow. So sometimes the medication itself is maybe more of the problem, that they just haven't been studied all that much. Detamir has actually recently been changed to category B, and remember, detamir has more of a bell curve, whereas glargine is kind of a flat line. And it has been shown, at least in one trial, to be non-inferior to NPH. So while NPH is still kind of the gold standard for longer acting insulin, detamir might replace that or be an alternative to that. That's all I've got for this lecture, so if you have any questions, let me know. Thanks.